Right. Trying to get everything ready so I can see it here. Okay, today we're going to continue with tactical field care. Our objectives today, we're going to list the physical findings suggestive of a pelvic fracture, demonstrate the appropriate application for a pelvic binder, demonstrate the appropriate procedure for setting up a ruggedized IV field setup, state the rationale for obtaining IO access, and demonstrate the appropriate procedure for starting an IO infusion. State the rationale for giving TXA for combat cases. Talk about the appropriate regimen for battlefield administration of TXA. Talk about tactically relevant indicators of shock and trauma in combat settings. Describe pre-hospital fluid resuscitation for hemorrhagic shock. We'll describe how you prevent blood clotting problems in hypothermia, management of penetrating eye injuries in Tccc, and list recommended agents for relief of pain in tactical settings, along with their indications, their doses, and routes of administration. Continuing with tactical field care, part 6 is circulation. Bleeding. A pelvic binder should be applied for all cases of suspected pelvic fracture. Severe blunt force or blast injury with one or more of the following indicators: pelvic pain, a major limb amputation or near amputation, physical findings suggestive of a pelvic fracture, unconsciousness or shock. Take a quick look at the bones of the bony pelvis. You can see the sacrum in the middle, ilium off to the side, the pubis down below, pubic symphysis where the two pubis come together, and the ischium. The pelvis is a butterfly-shaped group of bones at the base of the spine. It consists of the pubis, ischium, ilium, bones of the sacrum held together by tough ligaments that form a major ring in the center, and then there's two smaller rings on the side, as you can see. Treatment of suspected pelvic fractures in Tccc. Fractures of the pelvis are uncommon and range from mild, just being one of the minor rings being broken, to severe, as you see in this picture where the major ring is broken. Pelvic rings often break at more than one place. If you suspect a casualty may have a pelvic fracture, you should apply a pelvic binder. The binder is the field treatment for a pelvic fracture. We'll look at some life-threatening pelvic fractures. An open book pelvic injury, the front of the pelvis opens like a book. This injury results in a strong pelvic, from tears at the strong pelvic ligaments that hold the bony pelvis together at the pubis and at the sacroiliac joints. You can see how that pelvis is wide open. In a vertical shear injury, half of the pelvis is forced or sheared upward, and you see that in the bottom left. A lateral crush injury, half the pelvis is crushed either inward or outward. In each of these types of injuries, large arteries and veins can get torn, resulting in massive blood loss that can threaten a casualty's life. Pelvic fractures are really common in elderly folks and T-bone accidents, so think about those. Pelvic fractures in combat casualties. They're most commonly associated with dismounted IED attacks that are accompanied by major amputations. They can also occur in severe blunt trauma, such as motor vehicle crashes, aircraft accidents, hard parachute landings, or fall from heights. 26% of servicemen who died in OEF and OIF had pelvic fractures. Bleeding pelvic fractures with hemodynamic instability have a 40% mortality. So that's way more than an MI. Pelvic fractures and lower limb amputations due to dismounted IEDs. 77 consecutive patients with traumatic lower limb amputations after stepping on an IED. When you talk about associated pelvic fractures, if there's a unilateral amputation, 10% have pelvic fractures. If there are bilateral amputations, 30%. If it's bilateral above the knee amputations, 39% Overall, 22% had an associated pelvic fracture. And this is from the United Kingdom's Joint Trauma Registry. Okay. What exam findings suggest a pelvic fracture? Pelvic pain, laceration or bruising of the bony prominence of the pelvic ring, deformed or unstable pelvis, unequal leg length, scrotal, perineal, or perianal bruising, blood at the urethral meatus, massive hematuria, blood in the rectum or vagina, and neurologic deficits in the lower extremities. What type of pelvic binder should be used? There's 3 commercially available pelvic binders. There's a pelvic binder, the T-pod, and the SAM pelvic sling 2. 2 types of junctional tourniquets can also be used as pelvic binders, the SAM tourniquet and the junctional emergency treatment tool. What type of pelvic binder should be used? Any of the 5 devices could be used as a pelvic binder. The pelvic binder, the T-pod, or the SAM pelvic sling, or else the SAM junctional tourniquet with a junctional emergency treatment tool, the JET. Replacement of a pelvic binder. The pelvic binder should be centered at the level of the greater trochanters, not the iliacs. Okay, so keep it down low. Think of it more like a butt binder than a pelvic binder, right over the greater trochanters. Okay. In one recent study, 40% of the pelvic binders were placed too high. That resulted in inadequate reduction of pelvic fractures and possibly increased bleeding. Practical, we're going to do next time we have a skills station. We'll practice putting them on each other. Don't forget, external rotation of the lower limbs is commonly seen in people with a displaced pelvic fracture. This may increase the dislocation of pelvic fractures. The external rotation can be reduced by securing the knees together to improve the effect of the pelvic binder themselves. Remember, you don't log roll patients that have suspected pelvic fractures, so this could increase bleeding. As you roll people, the bones of the pelvis go back and forth, and any clots that may have formed can get broken loose, and any of these very light, small veins get torn, and people just bleed massive amounts from their pelvis from venous injuries. Don't forget, once the binder is on, additional procedures at roll 2 for hospitals may be required to access the groin. That's to say, a boa catheter may be moved up into the thigh. Definitive care delayed. If definitive care is delayed beyond 8 to 12 hours, the need for the binder should be reassessed and maybe loosened. Again, for civilian use, we're not going to have anybody 8 to 12 hours. Okay. It's reminders for the docs that watch this. Pelvic binders may mask the presence of a pelvic injury on CAT scan, because as you bind somebody, you kind of bring the pubic symphysis back together, but when they release the binder in that right-hand picture, you can see how that pubic symphysis opened right up. Questions? Guess not. Go over more on circulation, bleeding. Reassess tourniquet application. Expose the wound, determine if tourniquet is needed. If it's needed, replace any limb tourniquet over the uniform with one that's applied directly to the skin 2 to 3 inches above the bleeding site. Ensure that bleeding is stopped. If there's no traumatic amputation, distal pulse should be checked. If bleeding can persist or a distal pulse is present, consider additional tightening of the tourniquet or using a second tourniquet side by side to eliminate both bleeding and the distal pulse. If the reassessment determines that prior tourniquet is not needed, you could remove it. Again, we're talking tactical field care for deployed troops. You're in civilian use. Once you put a tourniquet on, you leave the tourniquet on. Tourniquet points to remember. Although a tourniquet may stop the active bleeding, it also prevents venous blood from returning to the heart. If you have an arterial blood that continues to get in past the tourniquet, Pressure could build up in the limb and create a compartment syndrome. This is why the tourniquet should be tightened so there's no longer a distal pulse, even if bleeding is controlled. This minimizes the chance of developing a compartment syndrome. Compartment syndrome can cause unnecessary loss of an extremity. I think for most of the groups during the practical, I mentioned that the 75th Rangers are now going to automatically putting on a second tourniquet for lower limbs. Go over tourniquet repositioning. Expose the wound and place a second tourniquet at least 2 to 3 inches above the most proximal bleeding site, and then loosen the high and tight tourniquet. If needed for hemorrhage control or to eliminate distal pulses, a high and tight tourniquet can be moved to position right next to that second tourniquet and tightened up. Remember, tourniquets have historically been frowned on in civilian trauma settings. In combat settings, they're the biggest lifesaver on the battlefield, but not a real problem if left in place too long, unless they're left in place too long. Damage to arm or leg is rare in a tourniquet that's on for less than 2 hours. Almost in any tourniquet we put on, this could be on less than 2 hours. Remember, tourniquets are often left in place for several hours during surgical procedures. And in the face of massive extremity hemorrhage, it's better to accept a small risk of damage to a limb than have a casualty bleed to death. Limb tourniquets and junctional tourniquets should be converted to hemostatic or pressure dressings as soon as possible if 3 criteria are met. First criteria, the casualty is not in shock. It is possible to monitor the wound closely for bleeding, and a tourniquet is not being used to control bleeding from an amputated extremity. Every effort should be made to convert tourniquets in less than 2 hours if bleeding can be controlled by other means. Do not remove a tourniquet that's been on for more than 6 hours unless you have close monitoring and lab capabilities. Every effort should be made to convert tourniquets in less than 2 hours if bleeding can be controlled by other means. If bleeding remains controlled with combat gauze, leave a loosened tourniquet in place. If the bleeding is not controlled with combat gauze, you can always retighten the tourniquet. Restoring blood flow to a limb by transitioning to a hemostatic agent at the 2 hour mark will minimize the chance of ischemic damage. I'm going to go over how you do a tourniquet conversion. First, you expose the wound. Converting a tourniquet to a hemostatic dressing is a simple process. First step is to expose the wound by cutting away the overlying uniform. The following sequence of slides will show how you convert them. First, tourniquets placed high and tight. Expose the wound. Apply combat gauze and a pressure dressing, any hemostatic agent, pressure dressing. Then loosen the high and tight tourniquet and move it down to just above the pressure dressing. And just leave it there, leave it loose. You monitor for bleeding. If the transition to hemostatic dressing at 2 hours failed, you can try it again at 6 hours using the same steps. Do not release the tourniquet after 6 hours of application if you don't have lab facilities with you. Because when you release a tourniquet that's been on over 6 hours, you can get acidosis, hyperkalemia, and rhabdomyolysis. All these substances get washed back into the bloodstream and can cause shock. Do not convert a tourniquet if the casualty is in shock, if you cannot closely monitor the wound for rebleeding, if the extremity distal to the tourniquet has been traumatically amputated, if it's been on for more than 6 hours, if the casualty will arrive at a medical treatment within 2 hours of application. That's us. There are tactical and medical considerations make transition to other hemorrhage control means unadvisable. Points to remember. Only medics, physician assistants, or physicians should reposition or convert tourniquets. Expose and clearly mark all tourniquets with the time of tourniquet application. No tourniquet applied and time of application, the time of reapplication, the time of conversion, and time of removal on the casualty's Tccc card. Use a permanent marker to mark tourniquet card. That's impressive. Go over questions later. Circulation, we'll talk about IV and IO access is indicated as the casualties in hemorrhagic shock or at risk of developing significant shock, and therefore they may need fluid, or if the casualty needs medication and cannot take them by mouth. An 18-gauge catheter or saline lock is preferred. If vascular access is needed, but you can't get an IV quick, use the IO route. Key point, not all casualties need IVs. IV fluids are not required for minor wounds. IV fluids and supplies are limited, save them for the casualties that really need them. IVs take time, and sometimes you get so distracted putting your IV in that you don't pay attention to what's going on. IVs can disrupt the tactical flow. Waiting 10 minutes to start an IV on a casualty who doesn't need it can endanger your unit unnecessarily. Do not start IVs in casualties that are unlikely to need fluid resuscitation for shock or for IV medications. You know, the alleged need to start 2 large bore IVs is pretty much a medical urban myth. We just don't do it anymore. The concept's outdated in the modern battlefield. Here are the casualties who really need IVs. Casualties with a gunshot to the torso may not be in shock, but they may be bleeding internally and go into shock later. So fluid resuscitation for hemorrhagic shock, significant shock, gunshot to the torso, casualties who cannot take medicines by mouth, unable to swallow, they're vomiting, they're in shock, or they have decreased state of consciousness. You do not need a 14-gauge catheter in the field. They're harder to start. A single 18-gauge catheter is recommended. It's easier to start than the larger catheter. It minimizes the supplies that must be carried. To say just carry 18s. All IV fluids given on the battlefield can be given to an 18-gauge catheter. And 2 larger IVs can be started in hospitals later if they're needed after the patient got into the medical treatment facility. Key points: don't put an IV distal to a significant wound. A saline lock is recommended instead of an IV line unless fluids are immediately needed. It's easier to move a casualty who doesn't have that IV line and the bag attached. There's less chance of a traumatic disinsertion. It provides rapid subsequent access if needed. It conserves IV fluids. You should flush the saline lock with 5 cc's of saline immediately and then flush it every hour or 2 to keep it open. Okay, let's see how this goes.
Site selection. The IV site has already been cleansed. Constricting band is in place. The tegaderm is resting to cover the IV site in its entirety. Sharp. IV plug is put on. The site is covered up 100% with a tegaderm dressing. Cut. The saline lock is flushed with 5 cc's of normal saline. You penetrate through the tegaderm and through the IV plug. At this time, the determination has been made that the individual has controlled hemorrhage and is in need of fluid. Notice that the 18-gauge, all of the devices that have these types of peelbacks are primed, so easy access. At this time, what we do is we introduce the 18-gauge 1 1/4 through the saline lock, and rest it at the hub. We then retract, discard the needle into a sharp shuttle, and apply fluids through that port. Monty, shift over here and show the delivery of fluids, please. Cut. This is a linebacker IV tubing or saline lock securing device. What we do at this point, never losing control of the tubing, we place this inside, put the tubing across it, lock it on itself, and wrap this around the arm. This secures the IV tubing while not impeding the flow of IV fluids. At this time, the determination during these fluid challenges, the determination has been made that the individual must be moved immediately. At that time, just take this off, pull the IV out, and disembark. The line or the saline lock site is still patent.
And that's a really great way of securing IVs. If you think about how many times you have lines that get displaced as you're moving people from your couch to the stretcher or just moving them around. The worst case scenario is that IV bag gets snagged. You'll unhook the tubing from your saline lock, but that saline lock is held down by the tegaderm. You'll never lose it. It's a great way of doing things. We'll talk about IO access. And for Tccc, they normally push the Fast 1 IO device, which is a sternal device. The most common military medical sets use the Fast 1. It's selected because you could use it in multiple extremity trauma. So somebody who's got multiple amputations, they've still got their sternum. So the sternal site's probably what the military goes to most often. If you look at it, there's an introducer. It comes with its own little sharp protection cap, foam plug, protector dome, target patch, insertion. Right. Fast 1 is not recommended if the patient is less than 50 kilograms or less than 12 years old. You don't use them if you suspect a sternal fracture or flail chest or there's significant damage at the site. This is a trauma infection. Can't use them in severe osteoporosis. Can't use them if there's a previous sternotomy scar. And the Fast 1 should not be left in place for more than 24 hours. Fast 1 flow rates by gravity, 30 to 80 mils per minute. Use a pressure infuser, you can get up to 120 mils per minute. And if you use a syringe force infusion method, you can actually get up to 250 mLs per minute using that. Note that the IO space connects directly with the intravenous space. We'll go over the Fast 1 insertion. Prepare the site with aseptic technique. Let's say betadine or alcohol. Remove the backing. Place a finger in the sternal notch. Place the target patch just under the index finger at the sternal notch and place it down. Remove the backing, label 2. Place the introducer needle cluster into the target area, and there's a little target you can see on that introducer patch there. The introducer device must be perpendicular to the surface of maneuvering, just like when we're needling chest. You want that needle to be at 90 degrees. Same thing with this, it must be perpendicular, or it won't work. All those little needles around the edge of the Fast 1 are just kind of positioning needles. They don't actually go into the patient. But if they're not all lined up right, the device won't fire. Align the introducer perpendicular to the manubrium. Insert increasing pressure until the device releases. That normally takes about 60 pounds of pressure. Maintain the 90-degree alignment to the manubrium throughout the procedure. Slow, steady pressure. Following the device release, the infusion tube separates from the introducer. Remove the introducer by pulling it straight back. Cap the introducer using the post-use sharps container. Be careful with the sharps. Connect the infusion tube to the tube on the target pass. You must flush the bone plug out with 5 10 cc's of saline, just like you do with a easy IO. And aspirate a little bit to make sure that you get some marrow back. You must flush that bone plug out. Connect the IV to the target patch. Open the IV to make sure you got good flow, and then place protection dome over it. Potential problems: you can get infiltration due to the insertion not being perpendicular to the sternum, inadequate flow or no flow, and that usually means that the infusion tube is occluded with a bone plug. So use another saline flush to try and clear that out. See how it's done?
Welcome, my name is Stefano, and today we're going to be discussing proper placement and insertion of an intraosseous device. This procedure is indicated when you cannot obtain peripheral vascular access and the patient requires life-saving medication or fluid. First step is you're going to prep your equipment. Be sure to bleed the tubing so you not introduce air into the sternum. Next, we are going to cleanse our site. After cleansing the site, we can locate our site by palpating the sternal notch midline on the manubrium. With non-dominant index finger, we are going to palpate sternal notch and place our target patch midline on the manubrium. After securing your sternal IO device, positioning ourselves at the head of the casualty, secure the IO device in both hands, aim it over the target zone, and be sure to introduce with equal pressure. We are now going to flush the IO tubing. Secure your tubing and attach it to the IO catheter. Be sure to aspirate and visualize for return of marrow or blood. Then flush your IO tubing. After flushing the IO tubing, we are going to secure the line. After securing the IO tubing, you can now administer fluids or medications in the IO device. Be sure to reassess your intervention, check your casualty's vitals, and annotate all patient care on a DD Form 1380.
After the fast one, the easy IO is the next most common IO used in combat. Overall experience has been very favorable. There's multiple different types of easy IO, and it's absolutely essential to choose the right device for the right location. They have a called a Talon. Basically, it's a hand device instead of the battery-powered one that you use, like the easy IO that we use for humerus insertions. Each of these are marked differently. Remember, you cannot use the long bone devices on the interosseous or the sternum. I've actually seen a CAT scan of somebody that had a sternal IO, started with an easy IO, and it actually went all the way through the sternum, and the whole mediastinum was filled with fluid. Okay, IO training safety. No practice on each other. You know, there's been times in the past where student volunteers have had sternal needles used on them. There is always a risk of osteomyelitis. It's not a big risk, but it's a risk. Just don't do this to each other. You train on simulators, not on classmates. Practical That'll be for our next practical session. Tranexamic acid. I'm a huge believer in tranexamic acid. Okay, it's a casualty's anticipated need for significant blood transfusion. That's to say they've got hemorrhagic shock, one or more major amputations, penetrating torso trauma, or evidence of severe bleeding. They get TXA. You administer 1 gram of TXA and 100 mLs of normal saline or ringers as soon as possible after injury. You don't give it after 3 hours of injury because it could actually cause an increased bleeding if given more than 3 hours or started more than 3 hours after injury. It should be given over 10 minutes by the IV infusion. The second infusion of 1 gram is after the first fluid resuscitation. TXA helps control hemorrhage. Tourniquets and hemostatic dressings help stop hemorrhage from external sites. TXA reduces blood loss from internal hemorrhage that we can't get to with tourniquets or hemostatic dressings. Got bleeding? Get TXA. It's now approved for point of injury treatment. It used to not be approved for this. Traumatic hemorrhage as of 2013 remains the leading cause of death on the battlefield. The Joint Trauma Theater experts recommend TXA as an adjunct to severe hemorrhage management. Back then, TXA was not FDA approved for this indication. It was considered an off-label use. Military services component commanders can authorize use of TXA. And again, now it's approved, so they don't have to worry about this. TXA is used for non-compressible hemorrhage. This non-compressible hemorrhage is the leading cause of preventable battlefield death. Tourniquets and combat gauze hemostatic dressings do not work for internal bleeding. TXA does. TXA is the medic's best tool for stopping internal bleeding. I guess most of y'all have heard me talk about the CRASH 2 study before. Over 20,000 people in civilian trauma centers. The MATTER study, which is a military application of tranexamic acid and traumatic and emergency resuscitation surgeries, had 896 casualties in Afghanistan. Both studies show decreased mortality when you use TXA. TXA does not promote new clot formation. Somebody's talking here. Okay. TXA does not promote new clot formation. It prevents clots from being broken down by the body. Helps stops internal bleeding. It prevents death from hemorrhage. 2 major studies have shown increased survival in patients that get TXA.
Yellow.
Yeah, it says Edward Cooper's talking, but I can't hear you. I want to stop for a second and we'll see if you want to send me a text. There's nothing else is coming across. Okay, and if you don't mean to talk, if you'll mute your audio, then it won't stop everybody else, okay? Okay, we'll go on. TXA's got the greatest survival benefit when given within 1 hour of injury. You get the greatest decrease in blood loss when TXA started as soon as possible. Give it as soon after wounding as possible. The survival benefit is present when given up to 3 hours after injury. Don't start it more than 3 hours after injury because there's a decreased survival if TXA is given after that point. It just makes common sense that trying to stop bleeding, you do it as soon as possible. I mean, you wouldn't wait till somebody gets to the ER to put a tourniquet on. Why would you wait till they get to the ER to give TXA? TXA is now FDA approved. Possible side effects: nausea, vomiting, diarrhea, visual disturbances. There's a potential risk of increased post-bleeding clots, but that's never really been seen. And hypotension can be seen if you give it too rapidly as a bolus, and that's why you give it over 10 minutes. Recommended storage temperature, kind of body temperature. Last, protect this drug from environmental extremes. Store and transport TXA in air-conditioned spaces. On missions, carry it in a small insulated container. You can carry it next to your body in a cold environment for room temperature storage after each mission. TXA is supplied in 1 gram ampules. It should not be given with Hextan or through an IV that's had Hextan in it. You inject a gram of TXA into a 100 ml bag of saline or ringers, infuse it over 10 minutes. Okay, and I just got a text, so I'm going to kind of stop things for a second and be back.
Edward, you there?
Okay, we're back. More on TXA. Second dose of TXA is traditionally given at a Rule 2 or 3 medical facility. So in the field, we'll only be given the first dose. It can be given after, in the field, after evacuation, or if evacuation delayed. Talk about fluid resuscitation. Assess for hemorrhagic shock. So we're looking at altered mental status in the absence of a brain injury or a weak or absent radial pulse. That's what we look for shock. We don't have to go off blood pressure or anything like that. Altered mentation, weak radial pulse or absent radial pulse, that's shock. We don't need to do anything else after that. Resuscitation fluids of choice. In order from most preferred to least preferred. Whole blood. And plasma, red cells, and platelets in a 1:1:1 ratio. Plasma and RBCs in a 1:1 ratio. Plasma alone, or RBCs alone, then Hextan, and then crystalloid, either ringers or plasma light. You notice normal saline doesn't even make this list. Fluid resuscitation. If the casualty is not in shock, you don't need IV fluids immediately. We're talking battlefield and combat casualties. If casualties can take fluids by mouth, let them swallow. In shock, and blood pressure, the blood products are available, resuscitate with whole blood. If that's not available, plasma, RBCs, and platelets in a 1:1:1 ratio, or plasma and RBCs in a 1:1 ratio, or reconstituted freeze-dried plasma, liquid plasma, thawed plasma alone, or RBCs alone. Reassess the casualty after each unit. Continue resuscitation until they have a palpable radial pulse and improved mental status, or a systolic blood pressure of 80 to 90. If in shock and blood products are not available, you can resuscitate with Hextan, Ringer's plasma light. You want to reassess the casualty after each 500 ml bolus. Continue resuscitation until they have palpable pulse, improved mental status, or a blood pressure of 80. Discontinue fluid when one or more of these endpoints has been reached. I mean, you think about how many times you see people that have 2 large bore IVs started wide open, and so you got 2 liters of fluid going, and everybody says, well, I'm going to reassess after I give a small bolus. But by the time you get all your other stuff done, you look back up, you have at least 1 or 2 empty bags, and the casualty you thought was going to get 250 ml bolus ended up getting 2 liters. If a casualty has altered mental status due to suspected TBI and have a weak or absent radial pulse, it's necessary to restore and maintain a radial pulse. You try and want to aim for a blood pressure somewhere in that 90 range. Reassess the casualty frequently to check for recurrence of shock. If shock reoccurs, check all external hemorrhage control devices, make sure they're still effective, make sure your tourniquet's still tight, make sure that your hemostatic dressing is good place, make sure your junctional tourniquet is in place. Currently, neither whole blood or platelets collected in theater FDA compliant because of the way they collected. This is an old slide now. Now it is FDA approved, so we'll skip it. A lot of people talk about shock without really understanding what it is. Let's clarify. Shock is caused by insufficient blood flow to the body tissues. This results in inadequate oxygen delivery and cellular dysfunction. If this state is not corrected, it will likely lead to death. Shock can have many causes, but on the battlefield, it's typically caused by severe blood loss. Hemorrhagic shock is the leading cause of preventable death on the battlefield. Let's talk about blood loss and see what happens and when it occurs. So how does your body react to blood loss? Well, the answer is it depends on how much blood you lose. For this demonstration, we have a slide that shows 5 liters of simulated blood. That's the total volume for a typical adult male. It's shown in 5 1-liter bottles to help with the demonstration. Got a 500 ml blood loss, so 4.5 liters of blood volume left. This is what you get when you donate a pint of blood at the blood bank. There's no danger at this point, at this level of blood loss. Keep in mind that factors like exertion, fear, pain can affect heart rate and breathing rate. And these will kind of affect anybody in combat too. So you may have somebody who's tachycardic just because they bled some and it's only a relatively small blood loss. So your 500 ml blood loss, mental status is alert, radial pulse to be full, heart rate normal, slightly increased, systolic blood pressure normal, respiratory rate normal. Is the casualty going to die from this? No. How about a liter loss? So now you only have 4 liters of blood. What are we doing now? So basically, okay. Heart rate may go up a little bit. Mental status is alert. Radial pulse is full. Heart rate maybe about 100. Systolic blood pressure will be normal when they're laying down. Respiratory rate should be normal. Is the casualty going to die from this? No. And basically, the heart rate's just up a little bit. Okay. How about another 500 ml of blood loss? How are we doing now? At this point, the casualty is starting to show some symptoms from his blood loss. He probably will not die from this. Mental status, he's alert, but maybe anxious. The radial pulse may be weak. Heart rate's going to be over 100. Systolic blood pressure may be decreased. Respiratory rates could be increased. Is the casualty going to die from this? Probably not. He's starting to show some symptoms from his blood loss. Okay, another 500 ml blood loss. On the battlefield, this will represent ongoing uncontrolled hemorrhage. How's the casualty doing now? So you only have 3 liters of blood left. 200 ml, 2,000 mils of blood loss. This is not good. At this point, it's quite possible that he or she could die from the blood loss. This is hemorrhagic or hypovolemic shock. Mental status, confused or lethargic. The radial pulse is weak. The heart rate's probably going to be in the 120s. Systolic blood pressure is decreased and the respiratory rate going to increase to be about 35. Is the casualty going to die from this? Maybe. At this point, it's possible he or she can die from this injury. How about another 500 mLs of blood? Now the casualty is in big trouble. He's lost half his blood volume. At this point, this level of hemorrhage is likely to be fatal. It's your job not to let him lose this much blood. Treating blood loss after the fact is not a good option. 500 or 2,500 mLs of blood loss. Well, they're going to be unconscious, radial pulse be absent, heart rate above 140, systolic blood pressure is markedly decreased, respiratory rate over 35. Is he going to die from this? Probably. Your job is not to let him lose this much blood. Yeah, these are the signs that you can reliably identify on the battlefield of a casualty. So you need a fast, reliable way of recognizing shock. Decreased mental status if they don't have a TBI or an abnormal character of the radial pulse. If signs of shock are present, control bleeding first, if at all possible. Hemorrhage control takes precedent over infusions of fluids. It's better to prevent shock by controlling it than to try and treat it. Even if shock's already present, the first thing to do is to stop ongoing bleeding. What does effect fluid resuscitation accomplish? There are 4 objectives: enhance the ability of the body to form clots, minimize adverse effects as, say, edema, dilution, restore adequate endovascular pulmonary organ perfusion. Prior to definitive control of surgery, we want to optimize oxygen carrying capability. If the casualty is not in shock, no IV fluids are needed. Save the IV fluids for casualties that need them. Oral fluids are permissible if a casualty can swallow. It helps prevent dehydration. And even if somebody's wounded in the abdomen, they can take oral liquids. The risk of aspiration is rare, and dehydration actually increases mortality. Conserve your precious medical supplies on the battlefield. Fluids for treatment of hemorrhagic shock. There's increasing awareness that fluid for resuscitation shock, or resuscitating casualties with hemorrhagic shock, is best accomplished with the fluid that's identical to what they lost, whole blood. The historic role of crystalloid and colloid solution in trauma resuscitation represents the triumph of hope and wishful thinking over physiology and experience. Updated fluid resuscitation plan. Whole blood, 1:1:1 plasma red cells platelets, 1:1 plasma RBCs, and then plasma, liquid thawed, dried, or RBCs alone, then hexstan, and then ringers or plasma light. Okay. This article from Military Medicine says fresh warm blood is the best pre-hospital resuscitation fluid, and that makes common sense. The 75th Ranger program, they got people that were known type O, low titer anti-A, anti-B antibodies, and these donors are pre-screened for the type that cures infectious diseases. The donor pool is used to transfuse casualties in shock. Type O, low titer whole blood with prolonged shelf life. Identify type O, low titer donors, collect it, screen for pathogens, and then ship them out. Fluid resuscitation, why don't we use these fluids? Albumin's not recommended for people with TBI. Volvulin, which is kind of like Hextan, is more expensive, could cause kidney injuries. Normal saline causes hypochloremic acidosis. Good rule of thumb is always remember that there's nothing normal about normal saline. Hypertonic saline, the fluid expansion you get is larger than if you give normal saline, but it's short-lived. We used to think that you give 250 mLs of hypertonic saline, and it'd be the equivalent of giving a liter of normal saline, but it's found really not to be superior. Like about hypertension, resuscitation. The goals in fluid resuscitation therapy is to improve the state of consciousness if no TBI. You get a palpable radial pulse that corresponds roughly to a systolic blood pressure of 80. You want to avoid over-resuscitation of shock and torso wounds. Remember, giving too much fluid volume can make internal hemorrhage worse by popping the clot. As you infuse fluids, blood pressure goes up. If it goes up too much, it could interfere with your body's attempt to clot off internal bleeding, both by diluting clotting factors, by increasing the pressure to the point that actually disrupts those clots. How much fluid do you give? Reassess the casualty after each unit of blood product for 500 mLs of saline. Continue resuscitation until a palpable radial pulse or an increased mental status with blood pressure in that 80 range. Do not over-resuscitate. Too much fluid or blood can raise blood pressure higher than needed and increase ongoing non-compressible hemorrhage. Switching away, we'll get to hypothermia prevention. Goals of hypothermia prevention, we're trying to minimize the casualty's exposure to the elements, keep protective gear on or with the casualty as feasible, replace wet clothing with dry as soon as possible, get the casualty onto an insulated surface as soon as possible. Apply the ready heat blanket from the HPMK to the casualty's torso, not directly on the skin. So you don't put the big warming thing directly on the skin, and then cover with the heat reflective shell. And we actually have a couple of these HPMKs that we're going to practice putting on during our next practical session. If an HPMK is not available, use a blizzard survival blanket or ready heat blanket. If they're not available, dry blankets, poncho liners, sleeping bags, anything that'll help retain fluid, help retain heat. Warm IV fluids are preferred if you can get them. Good point. Even a small decrease in body temperature can interfere with blood clotting and increase the risk of death. Casualties in shock are unable to generate their own body heat effectively. Wet clothes, helicopter evacuations increase the body's heat loss. Remove wet clothes and cover the casualty with hypothermia prevention gear. Hypothermia is much easier to prevent than it is to treat. Here we're not talking about hypothermia in the usual sense, which is drying from cold exposure. Now we're talking about keeping your blood clotting system working. Hypothermia is a problem for casualties in hemorrhagic shock, even in warm ambient temperatures. Prevention of hypothermia is the key. Once established, it's difficult to reverse. This is what the HPMK looks like. Basically, it's a full body warmer, kind of like the little hand warmers that you get at Academy. This one fits the whole body. Comes with this ready heat blanket and a heat reflective shield. The heat reflective shield helps retain the heat that's produced by the ready heat blanket. Apply the ready heat blanket over the casualty's torso, over the casualty's shirt. You don't put it in direct contact with the skin. It can produce temperatures of 104 degrees Fahrenheit for up to 8 hours. If it's in direct contact with skin, there's a small chance of you getting thermal burns. They may not work well at high altitudes because of the lower partial pressure of oxygen, but these are actually, it's a chemical reaction. Repeat, do not place the ready heat blanket directly on the skin. If reports of skin burns, keep the casualty's cami top or t-shirt on, place the ready heat blanket over the shirt. The previous HPMK had this hypothermia cap. Cap can be blown off by rotor wash, so you probably don't want to have that on if you're evacuating somebody by helicopter. Penetrating eye injuries. If penetrating eye injury is known or suspected, do a rapid field test. Cover the eye with a rigid shield, not a patch. Give the casualty 400 milligrams of moxifloxacin, which is in the combat pill pack, as soon as possible. Don't worry about eye charts. Okay, it's just, grossly, how well do they see? Have the casualty see if they can read print. If they can't read print, have them count fingers. Can they see hand motion? Do they do light perception? This is an example of a corneal laceration. That's the clear part in front of the colored part of the eye. Eye contacts can leak out of this injury. Bacteria can get in. Either of these two things is very bad. Look at this eye. There's that dark spot there at the 10 o'clock where the white part and the iris come together. There's a foreign body got penetrated in there. Attempts to wipe away this spot will cause more of the iris to get pulled out. Infection inside the eye is a bad thing. You don't want your buddy's eye to look like this. Make sure they get antibiotics. This is what endophthalmitis looks like. Remember, we protect eyes with a shield, not a patch. We want to keep pressure off the eye. The rigid shield protects the eye from pressure. If you put pressure, like the traditional, I'm going to put a patch on the eye and tape it up, you can actually increase the pressure in the eye and make the insides of the eye get pushed to the outside. You don't want that.
The procedures you will learn today are based on the principles found in the Tactical Combat Casualty Care Guidelines, the Institute of Surgical Research and Joint Trauma System Clinical Practice Guidelines, and Vision Center of Excellence recommendations. Medics, corpsmen, EMTs, and emergency response personnel, even bystanders or battle buddies, will most likely be the first responders to a scene. As such, your actions will determine if an individual's sight can be saved or lost. Although the eye accounts for only 0.1% of the total body surface area, eye injuries account for 10 to 15% of combat wounds and for 10 to 25% of injuries from natural disasters and terrorist acts. Over 30% of combat head wounds will have associated eye damage, as will many civilian and terrorist polytrauma injuries. And because the eye is notoriously unforgiving to damage, the initial treatment at the point of injury often sets the foundation for the ultimate outcome.
You know where you're at?
Do suspect eye injuries if any part of the eyelid or eye is damaged. There may be an underlying penetrating eye wound.
Give me Parrish. I need a medevac now.
Be particularly suspicious of any type of damage of any degree to any of the tissues that would otherwise be protected by eye armor or sunglasses. Eye injuries can easily be overlooked or missed. Blood, dirt, and debris that accompany trauma may mask eye damage and make the task even more difficult, as does darkness. The closer a laceration is to the eye, the more suspicious you should be that there is a penetrating eye injury.
Wrong company's here.
Unlike most wounds, where pressure is usually the appropriate first response, it is vitally important not to put any pressure on the eye. Patches, dressings, or gauze should never be placed under the shield or on top of the eye, as that could transmit external pressure, causing delicate intraocular tissues to extrude, leading to limited vision, blindness, or loss of the eye. The single most important principle in treating an eye injury is to protect the eye from pressure and additional trauma by applying a rigid shield over it.
Whoa, 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 whoa. Never pressure on the eye. Never pressure on the eye.
Sorry, Doc. How can I help then?
I need you to do exactly what I tell you to do.
Okay.
Get in the bag, give me 2 shields,
Gotcha.
if there are 2. If not, grab me some goggles.
The only time you should not immediately shield an eye is following chemical exposure. If dealing with a chemical injury, irrigate the eye immediately and copiously before doing anything else. Chemical wounds can quickly cause irreparable damage to the eye or even blindness.
Good thing those fuel cans didn't explode out there. We'd have some serious chemical issues to deal with.
Sergeant Bennett, can you and HM2 Janice come up and show us how you would place and secure the eye armor? Almost anything that rigidly vaults the eye can serve as an effective shield. Aluminum shields are malleable enough to allow for modifying the vault and contour as needed, while still maintaining rigidity. Polycarbonate shields are exceptionally firm and maintain excellent protection, provided the curvature is deep enough to clear the injured eye. In the event a commercially designed rigid shield is not available, various substitutions can be utilized. A primary alternative is the service member's anti-ballistic eye protection, or iPro. Because eye protection is made of ballistic-grade polycarbonate plastic, it is exceptionally rigid, even when slightly damaged. Similar commercial iPro can be used in civilian scenarios, such as runners or cyclist iPros. Other alternatives include the bottom of a coffee or paper cup, though this option may be more applicable to civilian and urban settings than remote combat environments. Yet another alternative could be using a moldable splint. In short, anything that rigidly vaults over the eye without touching it to prevent and redistribute pressure can act as an effective shield. Once the shield is placed over the eye, it can be secured in any fashion.
Do you want some saline or ointment?
No, we never put anything into the eyes. Never put anything in the eyes.
When authorized, start systemic antibiotics early within a military combat environment, but do so only if it does not induce nausea or vomiting. You want to minimize convulsive movement. If possible, check the vision in each eye separately, but do not pry open a swollen or closed eyelid in order to do this.
Your eyes, can you see me?
Yeah, I can see you, Doc.
Okay, great. Still see me.
Secure the eye with a rigid shield to protect and prevent further injury. The key aspect of any effective shield is that it vaults cleanly over the eye without touching the lid or eye, by resting on the orbital bones of the forehead and cheek. The shield will prevent direct pressure from reaching the eye, and it protects the damaged eye from further accidental direct trauma and environmental particulates. Thank you, Dr. Thomas and Sergeant Hall. Additionally, this is a perfect example of how to place iPro with a head wrap. Always place a shield or iPro over the eyes first, and then apply the wrap. Do not allow the wrap to cover the eyes directly, even if they are uninjured. Ocular injuries require prompt evaluation and treatment by specialists. The sooner the casualty is referred to an ophthalmologist for treatment, the better the potential outcome. Even though eyes are extremely delicate organs, they can be resilient if given a chance. Many severely injured eyes can be repaired at a medical facility if they are dressed properly in the field.
Go ahead, go get me a stretcher now. We're going to tie him up so we can get him out here.
Roger that.
By using eye shields, you'll be positioning your patients for the best possible vision health outcomes. It is the single most important action in saving vision. Remember, shields save sight.
and only one eye's been injured, don't place a shield on the other eye. Movement hasn't really been shown to affect the outcome for the injured eye. Blindness can make an otherwise ambulatory casualty a litter patient. And blindness of having that second patch on is real psychologically stressful. Tactical eyewear can be used to protect the eye if no shield's available. The use of tactical eyewear is the best way to prevent eye injury from happening in the first place. Monitoring, we'll talk a little about advanced electronic monitoring equipment if it's available. Analgesia on battlefields should generally be achieved as one of three options. Option number one, mild to moderate pain, casualty still able to fight. Excuse me. Combat pill packs got 650 milligrams of Tylenol. Take 2 every 8 hours, and meloxicam or Mobic, 15 milligrams once a day. Option number two, moderate severe pain. The casualty is not in shock and has no respiratory distress, and the casualty is not at significant risk of developing either one. Either transmucosal fentanyl, the fentanyl lollipop, place the lozenge between the cheek and the gum. You don't want them to chew it. Excuse me. Option number three, moderate to severe pain. The casualty is in shock or has respiratory distress, or the casualty is in significant risk of developing either condition. You give ketamine 50 milligrams IM or intranasal, 20 milligrams slow IV or IO. Ketamine's got a relatively short half-life, so you may need to repeat the doses every 30 minutes for IM or intranasal, every 20 minutes for IV or IO. Endpoints, control of pain, or development of nystagmus. Notes, casualties need to be disarmed after giving fentanyl lozenge or ketamine. Document the mental status exam prior to administration of opiates or ketamine. For all casualties giving opioids or ketamine, monitor the airway, breathing, circulation closely. Directions for administering the fentanyl lozenge. They recommend taping the lozenge on a stick to the casualty's finger as an added safety measure, using a safety pin with a rubber band to attach the lozenge under tension to the casualty's plate carrier. Reassess this every 15 minutes. You can add a second lozenge in the other cheek as needed and monitor for respiratory depression. So what you do is you've got your fentanyl lollipop taped to somebody's finger and they hold it in their mouth. When they pass out, the lozenge, their finger pulls their lozenge out of their mouth, and that way they don't overdose. The thing with the rubber band and safety pin is that same thing. As long as they're conscious enough to keep their mouth closed and it stays in there, as soon as they kind of pass out and their mouth opens, the rubber band pulls the fentanyl out of their mouth. IV morphine is an alternative to the fentanyl lozenge. If an IV has been started, give 5 milligrams IV or IO, reassess in 10 minutes. You can give a repeat dose every 10 minutes to control severe pain, but you got to monitor for respiratory depression. If you're given morphine, you have to have naloxone, Narcan available. Both ketamine and fentanyl lozenge have potential to worsen severe TBI. If the casualty is able to complain of pain, they're likely not having a severe TBI enough to preclude the use of using the fentanyl or the ketamine. We used to be told that eye injuries made it so you couldn't use ketamine. It turns out that's not really true. So the risk of additional injury from ketamine is really low. So feel free to use it for eye injuries. Ketamine may be a useful adjunct to reduce the amount of opioids given. So it's safe to give ketamine to a casualty who's already received morphine or the fentanyl lozenge. IV ketamine should be given over about 1 minute. If respirations are noted to be depressed after giving ketamine or opioids, provide ventilatory support for a few breaths. Ondansetron, Zofran, 4 milligrams, the orally dissolving tablet, IV, IO, IM, every 8 hours, nausea and vomiting. Each dose can be repeated at 15 minutes if the nausea or vomiting is not improved. Don't give more than 8 milligrams in any 8-hour period. Remember that oral Zofran is not the same as orally dissolving tablet. And that Zofran ondansetron is now the treatment of choice for nausea and vomiting. It's replaced Phenergan. Additional points on battlefield analgesia. The simplified triple option plan to battlefield analgesia has got 3 goals: preserve the fighting force, to achieve rapid and maximal relief of pain from combat wounds, and to minimize the likelihood of adverse effects to the casualty from the analgesic medication used. Nice thing about fentanyl lozenges, they don't require IV or IO access. They can be administered quickly, and it's very fast-acting. Fentanyl lozenge is almost as fast-acting as IV morphine. Very potent pain relief. You want to make sure that they do not chew the lozenge. There is an FDA safety warning regarding the use of fentanyl lozenges in individuals who are not narcotic tolerant. Multiple studies have shown when used at Tccc diet recommended doses, they're safe. Fentanyl lozenges are well documented for safety in Afghanistan and Iraq. But remember, don't use 2 and 1 will do. Dissociative anesthesia is what ketamine is. Distort perceptions of sight and sound, produce feelings of detachment or dissociation, to dissociate from the environment itself. At lower doses, ketamine is a potent analgesia with mild sedation. At higher doses, it becomes a dissociative anesthetic with moderate to deep sedation. It's unique among the anesthetics because the pharyngeal and laryngeal reflexes are maintained. Cardiac function is stimulated rather than suppressed, and there's much less risk of respiratory depression than with morphine or fentanyl. You can give it intramuscularly, intranasal, or IV or IO. Ketamine is recommended for battlefield analgesia and multiple combat things. It's recommended by some organizations as a single agent for surgical anesthesia in austere settings in developing countries. There's lots of parts of the world that ketamine is all they give you when they do your intra-abdominal or even thoracic surgery. It's just a really great drug. Ketamine's got a very favorable safety profile. Few, if any, deaths have been attributed to ketamine as a single agent. The FDA insert says ketamine has a wide margin of safety. Several instances of unintentional administration of doses of ketamine, 10 times that usually required, have been followed by prolonged but complete recovery. Read a case of I think it was a 5-year-old child that was actually given 5,000 milligrams of ketamine instead of 50 milligrams of ketamine. The child became dissociated, stayed dissociated for 12 hours, and then woke up in completely unremarkable recovery. And the neat thing about ketamine is, even when you do a massive overdose like that, you don't become any more dissociated. It's not like morphine or fentanyl or the narcotics that if you give too much, you get respiratory depression, go into shock, stuff like that. So ketamine is just a super safe drug. Small doses, it's great for analgesia. Larger doses, it becomes conscious sedation all the way up to complete dissociation. There's a middle dose where if you're trying for analgesia and you give too much, they can start getting high, and that's that special K that all the kids like when they do their recreational ketamine. And most people who know they've got that high, they kind of like it. But if you give a little bit more, then they become dissociated, and they don't know why they're dissociated, and that's when they just go crazy. The treatment of too much ketamine is more ketamine. It sounds kind of dumb, but that's kind of the way it works out. If somebody's in that dissociative state when they're just going crazy, give them more ketamine and just knock them out completely. Respiratory depression or apnea can occur if ketamine is administered too rapidly. If you give several breaths by a bag bath device, typically that's all you need. Aspirin, Motrin, Toradol, other nonsteroidals other than Mobic should be avoided in a combat setting because they interfere with blood clotting. Aspirin and Motrin, similar drugs, can inhibit platelet function for 7 to 10 days after the last dose. You definitely want to make sure you have your platelets working if you get shot. Mobic and Tylenol do not interfere with platelet function, and that's why they're our primary non-narcotic medications of choice. And, this we see, with deployed troops, they go to sick bay, they complain of aches and pains, and, they hand out Motrin like it's Ranger candy. But for another 7 to 10 days, some of these platelets are messed up. So they're trying to actually make it so Motrin, napkin, stuff like that are not even carried in the PXs where we deploy troops for that very reason. Warnings about morphine and fentanyl contraindications. Hypovolemic shock, respiratory distress, unconsciousness, or severe head injury. Do not give morphine or fentanyl to casualties with these contraindications. You could kill your casualty if you forget this. Ketamine can safely be given after fentanyl lozenge. Some practitioners will use a benzo, such as Versed, to avoid ketamine, but we've got to remember, Versed can cause respiratory depression, especially when used with opioids. Avoid giving Versed, clozapam, to casualties that have previously gotten fentanyl lozenges or morphine. You can kill your casualty if you forget this slide too. Zofran has been selected by Tccc to replace Phenergan as a treatment for nausea and vomiting in combat trauma victims. Its antiemetic effect is as strong as promethazine. It's frequent antiemetic choice in hospitals. It's increasing use in the hospital. So promethazine is no longer recommended. Ondansetron, more favorable side effect profile. Sedation is unlikely. It doesn't cause hypotension. There is a risk of QT interval prolongation, but that's really unlikely to occur when given under normal doses. It's neutral or synergistic given with opioids, and is no black box warning. Zofran used to be really expensive when sold as trade name Zofran, and now generics a lot more affordable. Remember, we use oral disintegrating tablet. It's not the same as the oral PO form. It works a lot faster. You don't chew or swallow it. You actually got to let it dissolve under the tongue. Zofran can also be given IV, IO, or IM. That's it for today. Hope y'all have a good day out there.